So our first speaker is Rosemary Wyber. Rosemary is a GP and actually graduated and received her PhD just 2 weeks ago, which is very lovely. Spoiler, she's not the only PhD up on the stage. There's a few. Rosemary, over to you.
Thank you so much. It is both delightful and slightly daunting to be the beginning of the end today, and a session which really looks at ending things. And for me, it's talking about the end of RHD in Australia, and there's been lots of RHD content during this conference for which we're tremendously grateful. But I guess I'm hoping to have a conversation now about the opportunities to be hopeful about what the end of RHD might look like and how achievable we think it is. But I'd like to acknowledge the Turrbal and Jagera people, the traditional owners of the country that we've been privileged to meet on, and to acknowledge their unceded sovereignty of this land, and also to acknowledge that I am a Pakeha non-Indigenous woman from Aotearoa, New Zealand, and that I'm really privileged to be supported by a number of Aboriginal and Torres Strait Islander researchers and clinicians and colleagues who make it possible to work in this space. And in particular, the leadership of Vicky Wade, who presented yesterday on the impact of rheumatic heart disease for Aboriginal and Torres Strait Islander people. And Vicky said yesterday that she was going to talk about RHD with Noongar statistics, that she was going to tell us what this disease really meant for people. And I'm going to talk about the other kind of statistics, the ones with the p-values, which is less impactful, but which I hope will be a companion part of the story about what really is possible if we pull together and really take action on this disease. But I guess before we get to the end of RHD, we have to think about the beginning. And these are the news headlines from the Sydney Morning Herald in 1949, and they talk about the scourge of rheumatic fever nationally. And specifically, the first line says, rheumatic fever was responsible for nearly 1/3 of deaths from natural causes in Australia, and was a greater killer than cancer or tuberculosis. That wasn't that long ago, and it was capital cities in Australia with a tremendous burden of disease. In fact, we've got some paediatric data from the Royal Children's Hospital in Melbourne, which looks at the burden of acute rheumatic fever hospitalisations in the 1930s and really shows that a socioeconomic gradient to this disease has always existed in Australia. The authors for this article talk about low rental areas being parts of Melbourne that they describe as slums, with overcrowded housing and poor access to sanitation. And we can see there's a really clear association that that's where the cases of rheumatic fever were being diagnosed. But that is no longer the case. This is hospital admissions to the same hospital, the Royal Children's Hospital in Melbourne, longitudinally over many decades. And what we can see is that the burden of ARF hospitalisations was really high in the 30s and 40s, and it fell precipitously after that time. There is still an enduring burden of disease, but it's nothing like the devastating rates that it was earlier in the mid-20th century. And that didn't take a dedicated program, and it didn't take a vaccine. This was a change in essentially social circumstances. But unfortunately, that change has been hugely and unjustly inequitable. These are the notification rates for acute rheumatic fever for Aboriginal and Torres Strait Islander people in Australia in the last few years. And what we can see is that the inverse is true, that rates are rising, not falling. And I guess that really begs the question, why is that inequity the case, and what can we do about it? So this is how we've always been taught to think about rheumatic fever, that it starts with a strep A infection, a strep A exposure, there's a throat infection, a few weeks later people get rheumatic fever, and with recurrent episodes of rheumatic fever they get rheumatic heart disease. But there hasn't really been a lot of work on the pathophysiology and the etiology of rheumatic fever since the 50s, when it literally was everybody's problem. And so there really has been a stasis in our understanding of this disease, and that's only just started to change, I guess, in the last couple of years, and a lot of that work has been led from New Zealand. So I just wanted to tell you about some of the emerging evidence which I think really informs some of our disease control strategies. So this is data from New Zealand. They had a huge program starting in 2013 which really looked at seeking out school children with skin sores and sore throats, swabbing those lesions, making treatment decisions. But because of a really quite sophisticated opportunity to link health records, they were also able to look at the outcomes of some of those things. It wasn't a research project, it was a public health project, but there's been opportunities to have significant research learnings. And I guess what we've been able to see from the New Zealand data is kind of what we'd expect. If you go out and swab children who've got skin and who've got throat infections with group A strep, then a few weeks later you see a spike of children who had positive swabs being admitted to hospital with acute rheumatic fever. And that's kind of reassuring because it's contemporary evidence for our more traditional understanding. But there's always been this question about what's the role of skin sores, and you've heard over the last couple of days that we're all quite comfortable saying, yep, skin's involved in this process, but we really, hand on heart, haven't had good evidence for that. It just seems to be strongly circumstantially the case. But this new New Zealand data is really providing important insights, and specifically, this is the same study with the same methodology, but looking at swabs that were positive for skin rather than for throat infections. And they look remarkably similar. So children who have those skin strep A infections a few weeks later have a spike in presentations for acute rheumatic fever. And so this is the best evidence we've had that it's both a skin and a throat association, which leads to that autoimmune sequelae into rheumatic heart disease. But we're also getting new evidence about the complexity and the importance of recurrent infections and what that means for immune priming. So this is another New Zealand study which used really carefully matched cases and controls, and they were matched on age and ethnicity and socioeconomic status and gender and geographic location and SES deprivation, really well matched. It's only 33 pairs. But what this paper was able to show was that if you take blood samples from children who've got acute rheumatic fever, then their median exposure to previous strains of strep A infection is 11. So there's a significant antibody evidence of previous recurrent or frequent strep A infections. But in cases, the median number of previous detectable strain infections was only 4. And that's a pretty significant and statistically significant difference. And what it really suggests is that recurrent strep A infections of the skin and of the throat are what's driving this burden of disease. And so it's not the linear process that's in a lot of textbooks. It's obviously a more complicated situation in the real world. But probably what's more important than that is what's really driving that burden of recurrent infections in young children, and we know that this is the case in Australia. And we talk really about the effects of colonisation driving the burden of this disease and so many other diseases that disproportionately affect Aboriginal and Torres Strait Islander people. It is no accident that Aboriginal and Torres Strait Islander people in remote northern Australia bear the brunt of this disease, which has disappeared from the rest of Australia. It is a source of endless frustration that we should even be needing to present evidence about these issues, and yet consistently there's a call from policymakers and governments that they need cost-benefit analysis, or they need modelling, or they need evidence of effectiveness. And I understand the drive for evidence, but fundamentally things like healthy housing is a human right. And so I think there's a real tension in this research where we say, how much of this should we have to prove? Those presentations in Melbourne didn't have to prove that running water is good for health outcomes. It just happened. But we are consistently being asked to tell stories with data to justify the kind of accelerated programming that's needed to address health equity in remote Australia. And I think that's a real tension. We have, however, been able to work on some projects which inform some of that decision making. So this is data from a project that we conducted in the Northern Territory, looking at clinic reported strep A infections and the association with household crowding. And not unsurprisingly, there's a strong association with household crowding. But what's notable here is that the median house occupancies were significantly higher than would be feasible for a 3-bedroom house in remote northern Australia. So what's clear is people are in environments where spread skin-to-skin contact, respiratory contact is frequent, and that is driving the burden of this disease. But the other manifestations of the legacy of colonisation and the active reality of colonisation in Australia is our healthcare system and how well or not well we're able to deliver disease-altering therapy to the people who need it most. So this is a study that was conducted in Western Australia, in Broome and Port Hedland's Hospital, which went back and looked retrospectively on a clinical record audit, like many of us have conducted in our training, at how many children who were being admitted under 16 years of age had documented skin infections of any kind, scabies, impetigo, tinea. And it looked like, if you looked at the records, about 22% or so of children had some kind of skin lesion when they were admitted. But then as part of that research, they also looked prospectively at children who were being admitted and went not actively seeking skin infections, but examined children more thoroughly and with more intentionality as part of a sort of pre and post process. And when they did that, they found that actually, in reality, more than 50% of children had some kind of skin lesion on admission to hospital for whatever cause. And that meant that children were 4 times more likely to have their skin infections identified if you actually prospectively went looking for them or did something about them. And that's a pretty significant difference between what is business as usual for us, that children come in with a range of conditions and may or may not have that kind of comprehensive assessment, versus thinking with a bit more intentionality about skin sores on presentation. And that really matters because primary prevention, so treatment of skin sores and sore throats with penicillin, can prevent a significant amount of rheumatic fever. And so this is a extremely aging forest plot of the efficacy of antibiotic treatment for primary prevention. And what it shows is, there hasn't been much research on this in the last half century or so. So we're making treatment decisions based on some pretty dated evidence now. But that the evidence that we do have is pretty compelling, that if you give people penicillin, that we can reduce their risk of developing acute rheumatic fever by about 80%, or the attack rate by about 80%. And that's potentially transformative. For children who live in environments with common and recurrent skin and sore throat infections, who've got a significant lifetime risk of acute rheumatic fever and rheumatic heart disease, any opportunity that's missed to deliver this disease-altering therapy is frankly indefensible. And it's a product of our system that we haven't been able to titrate our settings quite right yet on having the conversations, welcoming people to clinic, dealing with both the normalisation of skin sores and the stigmatisation of skin sores in some communities. So the tension for getting all of this right is complicated, but it shouldn't be insurmountable. And it's clear that with existing technologies, even though it would be great to have better ones, we can achieve an awful lot. So I guess the research question on a policy level is, okay, well, we could do lots of things. Which ones should we do? And this was the question that led us to a NHMRC-funded research project a couple of years ago called the End RHD CRE, or Centre for Research Excellence. This was the original brainstorming for the project, and the real research question was, there's a lot happening in RHD. Maybe we could lean into vaccine or penicillin reformulation, or maybe we need to think about improving primary prevention, or maybe we need to think about better diagnostics, because this syndromic Jones criteria business is, not really fit for purpose. And so we did a lot of work thinking about how do we make those decisions. And what became clear was the weight of evidence is very strongly around primary and primordial prevention. And that's no surprise to anybody. But by way of demonstration, there were some community-based projects looking at what this might look like in practice and some iteration of a model. This is some work that was done in 3 remote Northern Territory communities, which really centred around comprehensive programming to encourage people to get to clinic, supporting clinics to make good treatment decisions for skin sores and sore throats, and outreach from the clinic that was really led by Aboriginal community workers. And it's small scale, and this is a disease that is prominent in communities with small populations, and so that makes some of the research tricky. But in the first year of the study, there were 6 cases of acute rheumatic fever in the involved communities, and then over the following years, those numbers came down in a way that looked kind of reassuring. They weren't statistically significant. These are small numbers. It's hard to make sense of. There's a lot of epidemiologic bouncing around. But our sense is that there are acceptable models to community which have proof of concept to say we can go out and provide environmental health support, we can support clinics and communities and people at risk of acute rheumatic fever and rheumatic heart disease to have a disease-altering approach. And so our CRE packaged up many, many research outputs, and there's a technical report and a policy snapshot and an MJA publication and a storybook for communities, and we shopped it around to a lot of government. And in that process, we really tried to come back to government with what they'd asked for. You know, what would it take? How effective would it be? What do the numbers look like? And that brings us, I guess, to the modelling. So this was based on assumptions about the kind of efficacy of being able to offer health hygiene interventions, being able to do primary prevention really well, and those assumptions are obviously based on imperfect evidence. But if we do nothing, this is the prevalence of rheumatic heart disease over the next 10 years. If we simply reduce household overcrowding, we can nearly halve the burden of disease. And I appreciate that saying simply reducing household overcrowding is somewhat of a misnomer, but equally, it's not an insurmountable thing to achieve. If we support people to undertake what are called the healthy living practices, and that's the way housing and households and houses are used, so access to running water for washing hands and bodies, being able to wash clothes, protection from insects and things, we can make a further improvement in the burden of ARF. By supporting primary care, we can do slightly better again. And after that, we have less success in achieving transformative outcomes in preventing new cases. So by providing, say, secondary prophylaxis, we obviously don't have such an impact on incidence, although we know there's a significant obligation to provide best practice care for people who've already been affected by this disease that simply shouldn't exist. So we came up with a whole lot of policy recommendations, and we've been to government and called for funding, and there's a clear sense that we need Aboriginal and Torres Strait Islander leadership, that we need to support place-based initiatives for communities to do what they need to do. But I guess today I just wanted to talk about what I think the people in this room can do, and I think it really distills down to 3 important key areas. The first of which is being culturally safe practitioners. It is absolutely the case that Australia has a healthcare system which doesn't meet the needs of Aboriginal and Torres Strait Islander people every time they present to hospital and to primary care the way that they need. So I would urge everybody to be involved in practicing, encouraging, role modelling and calling out the need for culturally safe care to make it possible for Aboriginal and Torres Strait Islander people to seek the treatment they need. Secondly, I would encourage everybody to familiarise themselves with their local opportunities for referral and access to services. And so there's a growing momentum for access to environmental health, to get people on or accelerated through housing wait lists, for people to have referrals for housing repairs. So thinking about those things, connecting people to their local art shows or health services who may also have those networks and understanding those resources is an important value add. And finally, I'd say that risk-stratified treatment decisions for strep A infections are really important. I appreciate that the vast majority of sore throats in mainstream Australia are viral and appropriately not suitable for antibiotic treatment, but that is not the case in the people at risk of rheumatic fever. And there's really clear guidelines now about both for skin and throat infections, how that risk stratification needs to be done, and it's really important that we do that better. So I guess my call to action would be that I think we can end RHD because we have done it already in most of Australia. It is not acceptable to say that we have done enough, and it didn't take new technologies or transformative approaches. It just took basic access to adequate housing and to sanitation in ways that are fundamental human rights to achieve this change, and we all have an obligation to be part of making that a more equitable transition for all of Australia. Thank you.
Thank you, Rosemary. That's it's a sobering listen, and it is shocking. The work you've done is brilliant. Have we got any questions from the audience? Yeah, there's one up there. Brooke's got the mic.
I'm just wondering if you ever speak at conferences with, or if you're involved with the people building their houses, if you give the health perspective to the people who are actually going to provide the thing that's probably needed most.
Yeah, the housing and environmental health conferences are super exciting, and I think ripe opportunities for chat. So next week in Darwin is the National Aboriginal and Torres Strait Islander Environmental Health Conference, which is many of the housing people in one room. There's some really practical things that could be done. So there's a National Indigenous Housing Standards or guideline, which has sort of fallen out of both use and up-to-dateness. So the last update was in 2012. It provided a lot of really practical guidance about how houses in remote communities should be built. Unfortunately, it wasn't enforceable, so those housing standards were voluntary, and there's real issues around that. But it is absolutely the case that talking to health is important, but talking to housing is probably more important. But it's always a bit of a tension between the people who want to build the best kind of houses, and we've met some exciting new architects, and the people who want to pay for those houses. And there is, despite considerable vision in the environmental health community, less vision in the funding community.
Okay, thank you. We will move on to our next speaker, so a round of applause, please, for Rosemary. Thank you.